So that's essentially in a nutshell how fresh IVF works. Okay, now we'll talk about success rates. We'll talk about the medical clearance in a second, and then the cost as well. Well, let's talk about medical clearance now. Medical clearance actually, the things that are needed are pretty straightforward. You obviously want to make sure the patient's uterine cavity is normal. You want to make sure sperm is okay, up to date, etc. And then you want to make sure that all the patients have up-to-date STDs because you're going to be storing their tissues potentially if they have excess embryos in containers, so that have to be compliant. So these are, and every clinic is a little bit different about what other testing is required, but these are general principles that you want to make sure of before you start. And obviously, if the patient has any medical problems or medical comorbidities, you want to address them. Sometimes we'll put patients on blood thinners if they have a history of lupus. We'll obviously, if they have breast cancer and you're trying to do fertility preservation, these are all medical comorbidities you want to be aware of. So now let's talk about how a frozen embryo transfer works. So again, what we're trying to do is build on the principles of your understanding of how a menstrual cycle works and applying it to assisted reproductive technologies, which is, again, a manipulation and amplification of how a menstrual cycle works. So if you understand how a menstrual cycle works, then you can apply that knowledge to your understanding of how ART works. So in a frozen embryo transfer cycle, this is a lot easier. The patient already has frozen embryos, and we'll talk about that. So if we go back here, this patient may not, well, let's say this. In an IVF cycle, you might have 20 follicles, okay? Those 20 follicles might yield 18 eggs. Those 18 eggs, let's say 16 are mature. So not all of the 18 eggs will be mature. And let's say the fertilization rate, whether it's conventional or ICSI, assuming there's no male factor, is about 70%. So let's just make it easy. Let's say 75% fertilization rate. So you have 12 zygotes. And if the patient is like 36, 37, 38, or if they're older, then it is possible that some of their embryos will not make it to the third day and or the fifth day. So you might end up with 5 blastocysts. That's pretty good. You carry a high chance of success of live birth and, in fact, building your entire family off 5 blastocysts. Now, 5 blastocysts does not equal 5 babies, but it gives you a good chance of growing your family. So we talked about transferring 1 embryo on day 5. So what happens to the other 4 embryos that are in excess? Well, we typically recommend freezing them. And the reason for that is because they do pretty well in the freeze-thaw process. Embryos are pretty hardy, and their success rates are pretty good. We use a technique called vitrification to freeze the embryos, and they essentially when they can be frozen for an infinite period of time. This is helpful because let's say the first cycle doesn't work. If the first cycle doesn't work and you have frozen embryos, you don't have to go through all this again. This is where IVF is expensive. It's physically taxing. The patient has to come in for multiple tests and monitoring. The drugs are expensive. It requires a surgical procedure. So a frozen embryo, should you have excess embryos, a frozen embryo transfer is less demanding physically, financially, and emotionally. So if it doesn't work the first time, then you don't have to go through all that, and your cost is significantly lower. Yeah. Alternatively, if you're successful and you're ready for baby number 2, a frozen embryo transfer is a way to get baby number 2 without having to go through all this again. So again, in a frozen embryo transfer, you have to first medically and financially clear, and that's, again, just making sure that your uterine cavity is normal. And then once we get the clear, we start you on estrogen pills on cycle day 1. So you do estrogen pills, and you're usually doing estrace 2 milligrams 3 times a day. So we want you on a high dose of estrogen. And the reason for that, and we want to start on cycle day 1. And the reason for that is, remember, estrogen, yes, feeds back to the hypothalamus and will blunt the hypothalamus's communication with the pituitary and therefore the production of FSH. But if you give a low dose of estrogen, that effect is not that potent. So you have to give a very high dose of estrogen to prevent an endogenous FSH and ultimately endogenous LH surge from being mounted, because you do not want these people to ovulate. And I'll explain why in a second. So you'll be on these medications for about 12 to 20 days, and it varies. This is where clinics vary. And then ultimately you'll come in after about 12 to 20 days of being on the estrogen for an ultrasound and a progesterone level. And what we're looking for on the ultrasound is, if I were to draw a cartoon version of the uterus, you want to see what looks like a trilaminar pattern. Let's show you what that looks like. So you see here, this is a sagittal view of the uterus. Here's a sagittal view of the uterus. And then here's the uterine cavity. This is what you would expect to see in the mid to late follicular phase, i.e. the mid to late proliferative phase. You would expect to see this trilaminar appearance, 1 line, 2 lines, 3 lines. That's what you want to see. You can see there's more views here. This is a pretty good one here. So that's what you're looking for. You want to have a nice trilaminar appearance. And then you also want to make sure the patient has not ovulated. So you want that progesterone level to be less than 2.5. If it's less than 2.5, that means the patient has not ovulated. That's important, because if the level is above 2.5, that means that she's going to start, her endometrial lining is going to start seeing progesterone, and it's going to advance, so that when you're ready to transfer the embryo, the lining will actually be post-receptive compared to the embryo. So that's why it's critical to check a progesterone level to make sure this patient has not ovulated. If the patient's lining looks good, the progesterone is less than 2.5, then you'll continue the estrogen, and then you will start, more importantly, progesterone injections. Now, let's say the progesterone, well, let's just keep going. On the 5th day of the progesterone, we thaw the embryo, and then on the 6th day, we transfer the embryo, and then 6th day of progesterone, 5th day of progesterone. And then they continue the progesterone and the estrogen, and then 12 days later, they check a blood pregnancy test. Now, if their pregnancy test is normal and positive, then they will continue the progesterone and the estrogen for 10 weeks. Because remember, this patient is not making any progesterone on her own. She is relying on you completely to replace it. So she's giving herself daily intramuscular injections in the hip. It's hard to do that, by the way. So she's doing that for 10 weeks to help support implantation. By about 10 weeks of estimated gestational age, the placenta should be making its own progesterone, and you can stop the progesterone injections. If the progesterone level was, let's say, 1.0, normally the progesterone level in this, you'd expect it to be less than 1, but let's say it's starting to creep up a little bit. It's 1.2. In that scenario, and let's say also the patient on ultrasound has a 20 millimeter follicle. Okay, so in that scenario, the patient may actually ovulate soon. If you give the patient that high dose of progesterone, that will prevent her from ovulating. Remember, because high doses of progestin in general, progesterone in general, think of birth control pills, progesterone will inhibit the LH surge. So by giving a high dose of progesterone, you are in effect preventing that patient from ovulating endogenously. So people will sometimes ask, okay, well, what if we're having intercourse? How do we know it's not from us spontaneously conceiving and not the embryo that we transferred? Well, first of all, most of the time the patients are infertile for some obvious reason. So it's not likely that they're going to spontaneously conceive, but many people it's possible. So you tell them that I'm preventing you from ovulating by giving you that progesterone. So there's no way you can conceive spontaneously. So that's how a frozen embryo transfer works, essentially in a nutshell. I did talk about how long we give the progesterone. In a fresh cycle, we would give it for 8 weeks. So we give it. The convention in the United States is to do it a little bit shorter. The European colleague do a little bit shorter than a frozen, and that's in general because that in a fresh cycle you're supplementing, whereas in a frozen cycle you're replacing the need for progesterone completely.